Hi everyone, today I'm here with Dr. Katinga, a forensic psychiatrist who practices inpatient community psychiatry as well as some forensic psychiatry. So, Dr. Katinga, thank you so much for being a part of this interview.
You're welcome, thank you.
And before we go into the details of or specifics of psychiatry and inpatient psychiatry, could you briefly describe what inpatient psychiatry involves, maybe the most common cases, as well as forensic psychiatry?
Sure, that's it's a pretty tall order. It's a big question. In inpatient psychiatry, let's start with that. It runs the range. So you see all kinds of folks, including folks with mood disorders, psychotic disorders. My area of expertise is more towards psychotic disorders and bipolar disorder. But as an inpatient psychiatrist, particularly in the community, you run the range from generalized anxiety disorder, panic disorder, post-traumatic stress. I think the bulk of my work, though, inpatient, comprises people with schizophrenia and bipolar disorder. Yeah.
Okay, and what about for forensic psychiatry? What kind of cases does that involve usually?
So forensics also is a pretty broad field. And you roughly divide it into civil work and criminal work. The work that I do is criminal work, and I do mostly what are called criminal competencies. So I do competency to stand trial evaluations, and then also not guilty by reason of insanity cases. Those are the two kinds of cases that I do mostly. But I have colleagues in the field that do much more. They do fitness for duty evaluations, psychic harm cases, malpractice cases, so it runs the range.
I'm assuming forensic psychiatry is a fellowship that you do, and is inpatient psychiatry a fellowship, or is that like a track that you do in general psychiatry?
So I'm going to start with the second question first. When you finish medical school and you decide you want to be a psychiatrist, you enter into a general residency program, and if you're going to do general adult psychiatry, it's a 4-year program. If you're going to do child psychiatry, I believe it's a 3-year program plus a 2-year fellowship. So that's 5 years total if you're going to do child psych. But once you're done, if you just go into the community, you can pretty much choose the kind of work you want to do. You can choose to do outpatient work. You can choose to do inpatient work. I think some of that is personality-based. I know I don't have the personality for outpatient work. I like high acuity, very ill patients, and so I choose to do inpatient work. So you don't need any extra training on top of that. The way the most psychiatry residencies are set up, you have a good mix of both inpatient and outpatient training. So theoretically, you should be well equipped to do any kind of psychiatric work when you're done. Now, to answer your first question, forensics is a 1-year fellowship on top of whatever general residency you do. So I know folks that do child forensic psychiatry, so they're doing 5 years of both general psychiatry with the child fellowship, and then another year on top of that of forensics. But with that extra year, again, it's wide-ranged. You can divide it up into civil work, criminal work, and really it's just preference for what you want to do.
What's a typical day in your life like, from when you start working to when you leave?
I filled my plate pretty full. I have a big family. I have 7 kids. That means I'll be working till the day I die. So I bulked up on a lot of work. I would say that my work day might be a little atypical for most, but right now I do two different hospitals. So I'm working at Sierra Vista Hospital and Sutter Center for Psychiatry. So typical day for me now, I usually start my day around 7 in the morning. I go to one of the hospitals first, usually Sierra Vista Hospital first. I round on my patients. That includes any new admissions that I get. And then I do all my documentation for those patients. I do all my orders. Sierra Vista is sort of a nice old school hospital with paper charts, so you're actually writing orders. You're dictating notes that get transcribed and put into the chart. So yeah, it's a busy hospital. There's more than 120 beds at that hospital. And then after I'm done at that hospital, I usually go to Sutter. I have a very limited caseload at Sutter. I only have between 4 and 8 patients there. But it's the same kind of work. I round my patients. It's a little more structured there. I should mention every hospital has its own culture. And at Sutter, we round with a social worker at times. But I round my patients, I put in orders. They have a nice electronic medical record system. So it's a little more streamlined there. And then when I'm done, I also have been teaching for your school. So I usually go back to Sierra Vista and do the bulk of my teaching there. So for instance, this last rotation that was with me, I would start seeing patients with them around noon until we were done, so sometimes between 2 and 4. And then on Wednesdays and Sundays, I do telepsych. It's another thing that I do. I'm pretty new to telepsych, so I just started that, but it's pretty nice. You work from home, you wait for calls, you see them on the computer, and at the end of things, they pay you to do it. So I do a lot of different work. So I would say that my day usually ends at different hospitals at around 4. And then if I'm doing telepsych, my day won't end until 11, so I usually do a 7 to 11 shift.
How does that differ from maybe other psychiatrists? Would you say you said that's a little bit atypical?
I would say that's probably atypical. I probably work more than most. But one thing I should explain is, when you're done with training and you go to work, I mean, there's a number of ways that you can work. You can pursue a salary position. You can pursue a university hospital kind of a setting where you have a set salary and you do the work that they tell you to do, and then you get paid. But now I'm doing contract work. I used to work at UC Davis. I was there for 8 years. But when I went into the community, that's all contract work. So you don't get paid a salary. You get paid per patient seen, essentially. So the freedom and the benefit is the more patients you see, the more you earn. If you get burnt out, you can stop taking patients and rest a little bit. So you have a little more flexibility. I would say most of the colleagues that I work with, contractors, they all have second jobs. I mean, at least everyone at Sierra Vista does. They all have different things that they do. Some work like a partial hospital program. Some do other correctional work. I think I'm the only one that has probably three gigs going plus teaching. So that's a little atypical for that. I think compared to salary positions, I mean, it's definitely atypical. You have a salary position, you're pretty much just working for your employer. And I'm not sure if it is a norm, but I know a lot of places, if you're a salaried employee, they have no competition clause. So you can't really work anywhere else, even if you wanted to.
Mm-hmm. How is the lifestyle of an inpatient psychiatrist different from that of another specialty?
And I would have to say that the lifestyle is pretty great. So despite the fact that I'm working a lot, I have a lot of control over the hours that I work. I'm working a lot because I'm choosing to work a lot. I could easily just ditch 1 or 2 of my jobs and I would have a lot of free time on my hands, and that's great. As far as comparing to other specialties, I just don't know. I mean, I assume that hospitalists, if you're in internal medicine or family medicine, I assume that hospitalists have a similar kind of lifestyle, similar kind of work-life balance. But at least from first-hand experience, I really love the fact that I can control how much I'm working, so my life can be as leisurely as I want it to be. I just have to know that if I make it leisurely, I'm not earning as much.
It seems like you do multiple things and that there are opportunities in your field of psychiatry to do, and maybe even just psychiatry in general, to do other things like research or multiple jobs or like telemedicine or other things like that. Would you say that's pretty much true for like any like psychiatry practice as opposed to maybe like some of the other specialties? Or, for example, I interviewed a cardiologist who said it's hard for him to do anything really outside of it.
It's hard for me to answer that question because I just, I don't really know. I have one good friend who's a plastic surgeon, and he's pretty much busy all the time, and he's sort of on the leash of his employer. So if his employer says he's got to do something, he's sort of got to do it. That's the only thing I can really compare it to. I mentioned I have a big family. Because I have a big family, I actually don't have a lot of friends. I don't really know what other people are doing. So unfortunately, I don't know that I can answer that question with confidence.
What's the most challenging aspect of your field of psychiatry?
If you're talking about my own personal experiences in psychiatry, I'd have to say the most challenging and rewarding thing would be the teaching aspect. I actually do like to teach. I usually take on a few students per month, and I really invest myself in trying to build an enthusiasm for the field. I know that many people are not going to go into psychiatry, but I think there is a lot to be learned from dealing with people with mental health problems. I think it forces you to think about your own life. Psychiatry I think, is one of the fields where you are constantly weighing someone else's actions against what you would do. It is sort of a comparative field in that sense. In the most basic sense, the job of a psychiatrist is determining what's normal. And most people, by force of habit, compare what's normal with what they themselves would do. And so I think having an opportunity to see psychiatric patients, it forces you to reconsider the things you do and sort of weigh the merit of the things that you do. So I think giving that instruction to students, teaching students to value that experience, that is the most challenging and rewarding part. If you're talking about the field, knowing other psychiatrists, I think probably the biggest challenge is learning how to let things at work sort of stay at work. At least if you do inpatient psychiatry, you can see some pretty terrible things. In forensic psychiatry, the kinds of clientele that I see, you can see some pretty terrible states of the human condition. So learning how to compartmentalize that, learning how to leave those things at work, and keeping your own life separate from all of that, I think that's probably the biggest challenge.
Are there any misconceptions about being a psychiatrist?
Yeah, I think so. It sort of speaks to how I even got into psychiatry to begin with. When I first started medical school, I thought I wanted to be a surgeon. I thought I wanted to be a transplant surgeon. That's one of the reasons why I chose to go to Pittsburgh. I graduated from the University of Pittsburgh. Went to Pittsburgh because they have a big multi-organ transplant program. And I wanted to be around what I thought I was interested in. But what I discovered is Pittsburgh also has one of the finest psychiatric programs in the country. And I actually grew to really enjoy psychiatry. Even from the first rotation I had, I knew that there was something about psychiatry that I wanted to do. But I was always tripping over my own biases about psychiatry. I always started to wonder, well, if I go into psychiatry, am I wasting my medical student education? Am I going to be a real doctor, so to speak? It's sort of funny, my parents not really understanding what psychiatry was about. They even asked me, well, hey, you're going to go into psychiatry, I thought you were going to be a doctor. So there is a bias. There's a bias regarding the validity of the field. And I think part of that bias comes from the fact that unlike other fields of medicine, we heavily rely on the patient's subjective experience to develop our assessments and treatment plans, as opposed to other fields where you can rely a little more heavily on objective findings. For us, objective findings are the patient's subjective report. So you're sort of translating someone's internal experience into something tangible that you can work with. And I think that's where part of the problem comes in. So yeah, I think there are definite biases. I think most people in the community probably have their own biases because mental illness presents in such a bizarre fashion. You're not accustomed to seeing people act in certain ways, and so you start to develop a bias about who that person is, what they're capable of. It's strange, so it must be dangerous. So I think there are certain biases relating to that as well.
What was the real draw for you when you decided to pursue psychiatry? Was it that kind of philosophical mindset that you brought up earlier, where you're kind of weighing the patient versus like your own kind of like internal perspective, or was it something else?
I think some of it, some of it definitely was just the attraction to things that were bizarre. So my very first experience, I was a third-year medical student. My very first clinical rotation as a third year was at our psychiatric hospital. And where I trained, it was a big 300-plus bed inpatient psych hospital. And each floor is divided by diagnosis. It was really great. So I was assigned to the schizophrenia floor. And I had my keys, and I entered the unit, And the first thing I saw was a patient had another patient hoisted up clear over his head. And he was politely instructed to put the other patient down. And he did. He put him down. They both walked away like nothing was happening. And it was just a bizarre thing to see. And it was really intriguing. I mean, what is that all about? So there was an instantaneous attraction there. But as I did more work in psychiatry, I took on other rotations in psychiatry. One of the other things that started to draw me was just how each condition can present in so many different ways. So schizophrenia in one patient will look completely different from schizophrenia in another patient. Even things like major depression in a 13-year-old kid is going to look completely different from depression in a 72-year-old woman. So the variability in presentation definitely had an intellectual challenge that was very appealing to me. It's not always going to be cut and dry. Certain conditions will look the same irrespective of the patient. So diabetes is always going to look roughly the same. Congestive heart failure is always going to look roughly the same, but that's not the case in psychiatry.
Are there certain personality types that you would say are best suited for psychiatry?
That's a hard question because I personally believe that every personality type, every personality structure can offer something to the field. You definitely don't want a field full of all the same kind of person. You need voices of dissent. You need other opinions about the field to make the field grow. Otherwise the field can stagnate if everyone has the same mindset about the field. So that's a hard question. I think if you're going to do forensic psychiatry, you have to have the kind of personality that has a healthy level of skepticism. Because a lot of what you're asked to do is to determine the quote-unquote truth of a situation. Sometimes you'll be asked to determine if someone is malingering an illness. Whenever you're doing a criminal case, you always have to wonder how much of the account that you're receiving is being colored by the patient's desire to avoid some kind of legal repercussion. Even when you're doing inpatient community psychiatry, not a lot of people want to be in a psych hospital. A lot of people want to leave. So you have to be aware of what the patient may intentionally or unintentionally be doing to try and facilitate their discharge from the hospital, even if they might not be ready. So I think if you have a healthy level of skepticism, it sort of lends itself to the field.
Okay. And what kind of tips would you give medical students to match into a competitive residency program in psychiatry and a good fellowship in whatever it is, whether it's like forensic psychiatry or another subspecialty?
I think the foremost advice I would give is to research residency programs in the area of the country that you'd eventually want to live in, find out which ones are good, and try to seek away rotations at those sites. And I think that's true for any field, whether it's psychiatry or not. I know as someone who used to work at UC Davis and sort of seeing how things were when I was still at University of Pittsburgh, having candidates come to the site and being able to observe the way they do things, that does so much more for the candidate than in any interview can. So I'd probably say that's the foremost advice, is looking for those away rotations at the programs that you potentially might want to go to.
Okay, so moving on to kind of maybe like some of the financial aspects. You mentioned that there's a lot of different kind of like settings that psychiatrists could work in. So could they do like locum tenens work, or it seems like you do some private practice work, or do most psychiatrists work in like big groups? And
I don't know what most psychiatrists do, but contract work is essentially private practice work. So technically the work I do is a private practice. If you have an outpatient private practice, you need a location, right? You need office space. If you're doing inpatient private practice work, a lot of times you're contracting with the hospital or organization that is managing the patients. So for instance, my work at Sierra Vista Hospital, I don't get paid by Sierra Vista Hospital. I get paid by the insurance companies of the patients that I see at Sierra Vista Hospital. Sierra Vista Hospital does give me a bit of a stipend to facilitate certain administrative duties for the hospital, but the bulk of my pay comes from the patients. So technically it's a private practice. Locum's tenens work, you definitely can. You get so many emails from different organizations that, hey, come down to Santa Barbara. We have a 1-month gig. And, if I didn't have a family, it'd probably be pretty appealing just to go somewhere and work in a different environment. There are different ways you can earn money. I just don't know how most psychiatrists do. I don't really know what the stats are and what percentage of people are salaried or what percentage of people are contractors and private practice people.
But it seems like there is a lot of opportunity to kind of mold your practice into whatever you really want it to be.
You can do whatever you want, for sure.
And how much do psychiatrists make relatively, generally, and like relatively compared to like other specialties?
I think I asked some of your colleagues this before. What are you being told a starting psychiatrist makes? I forget the source, but when I was finishing up fellowship, I actually researched this. This is way back in 2005. And I think the average, and I forget what source it was, so I don't know what the validity of this was, but I think the average starting was like 185. I don't know how it compares to others, because I wasn't interested in doing other kind of work. But what I can tell you is, having worked at UC Davis, having now worked at Sierra Vista, Sutter, Woodland Hospital, all the bunch of other stuff that I do, like teaching and telepsych, you can make a comfortable living.
What strategies would psychiatrists use to increase or maximize their income? Is it one of those things where it's more just like the hours you put in is the income output you get, or is it like there's certain things you could do, like for example, like some let's say like internal medicine doctors might start doing like certain procedures to like increase their income, but psychiatrists don't really have procedures, right? So
that's not true. ECT is technically a procedure. You get paid per procedure. It can be fairly lucrative. Forensic work can be lucrative, but the lucrative work in forensics is in civil cases. It comes with some risk. Criminal work is nice and safe because you're being asked by the courts to make an opinion, and if the court is asking you to do something, your opinion tends to be protected, so to speak. Civil work, you can earn more, but the risk is a little higher because you have to be really rock solid in your rationale for coming up with a certain decision or opinion. But there are definitely ways that you can earn. Some things definitely are lucrative compared to just run-of-the-mill patient work.
How do you stay on top of all the advances in your field?
Conferences. For me, it has to be conferences. With as much as I have happening at home, having a family is very important to me. I can't try to rationalize to my family why I need to spend another 2 hours at home being away from them when I just spent the whole day away from them at work. So I really need to make sure I consolidate my learning. So it tends to be conferences. When I still had a bigger interest in forensics, I was going to the yearly forensic conferences. Now I make sure I go to the APA every year just to sort of keep up with what other people are doing. So that's the bulk for me. Some people do it differently. Some people do online CMEs, different ways you can get it.
Okay, and with the heavy types of cases that you see, how do you avoid burnout?
It's like what I was saying before. You just got to learn how to leave it at work. I'm pretty strict. I set a lot of limits when I'm not at work. I don't want people calling me when I'm not on call. And I think surrounding myself with my family definitely helps. So when I get home, just sort of being with them sort of shields me from thinking too much about what's happening at work. I don't know how much of a choice that is because people have different personality structures, and some people have an easier time doing that than others. So I guess I'm lucky in the sense that I don't have a problem leaving work behind.
So I was going to ask how you establish a work-life balance with 7 kids and working like 3 jobs, is it?
Well, the work-life balance, I think, I don't really do a lot for myself alone, I should say. I used to be heavy into biking. I have other hobbies that I'm heavy into. I play piano. I do a lot of other things solo, but I don't do a lot of solo things anymore. My kids are getting older. I'm sending one to college this year. And it's more important for me to be around my family. And that's okay. I don't miss the solo stuff as much as I used to, or as much as I thought I would. Like I don't miss it. I mean, I would love to get on my bike and take like a 50-mile bike ride, but I don't really miss it because I don't want to miss anything here at home.
So the way you kind of balance a large family with being a doctor is to prioritize them over in your free time over like other hobbies, like solo things, basically.
Yeah, basically. When I was younger, I would get really into things, like hobbies I would have. It wouldn't just be enough to do it. I'd need to like start reading up about it, start looking at magazines about it. I remember when I started biking, just like everything was about bikes, and I would get really into it. I don't know, you just sort of lose that. I came to realization, if I'm going to spend 2 hours on the trail, I'm going to come home and like everyone's going to be either deep into homework or getting ready for bed. And yeah, I would have had fun on the trail, but then it's not as fun because you get home and you missed everything. So yeah, I guess just diving into family stuff.
And you mentioned that you had your first child, in your first year out of medical school when you were an intern year, which is like supposed to, like known to be like the hardest perhaps year of your medical training, right?
Yeah.
Is that something that you'd recommend, or when would you recommend having a family in the medical training process?
So having 7 kids, I can tell you, my opinion is that there's never a good time to have a family. Because there's always something that you think in your mind is going to get in the way of something. You're either going to think that the family's going to get in the way of something that you're pursuing in terms of a career, or you're going to think your career is getting in the way of your family. There's no good time. And so knowing that, if you know you want to have a family, just have a family. If you know you want to get married, just get married and make it work. I mean, I know it sounds really oversimplistic, but I think it is a truth about having a family and being a professional. Because there's no good time. You can always rationalize that it might be a better time in a year from now.
Yeah.
But a year from now comes and there's other reasons why it may not be a good time. So don't wait. Start right away.
Okay. It seems like you do, or you said you started doing telemedicine in the past like year or two?
Really just the last, since winter.
Okay.
Since December.
Mm-hmm. Telemedicine seems to be like one of those things that's kind of been happening, and that's gonna maybe take over a lot of how medicine is done and healthcare is like kind of conducted over in the future. How does the whole thing work? Like, do you need licensing in whatever states you're like telemedicine into? How does that whole thing? How's compensation and all that stuff? Like, how does that work?
So what I'm doing is I'm working through a company that has telemedicine contracts with different facilities, mostly dignity facilities, and they pay me per consult. So this is a situation where the company I work for actually pays me. I'm not getting paid by patients or patients in insurance for telepsych. So I signed a contract with them. It's like credentialing anywhere else. So, for instance, when you decide you're going to work at a hospital, you have to get your credentialing done. You need to make sure that they have proof of all your training, that you're keeping on top of your CMEs. They need to make sure DE license is in order. So they do a lot of things. If you're going to do telepsych, you need to have your credentialing done for every site that you're going to provide services for. So, I had quickly had to get credentialed for 15, 16 different sites. And that's a lengthy process. So there's a lot of waiting. I started a credentialing process back in early fall, and I didn't start seeing my first patients until January. It takes a long time. But yeah, you get paid directly from the company per consult. And usually they give you money. Let's say it's a slow night and you get no calls. They usually give you a little money for that. So that's how it works for who I'm working for. And I think that's probably similar to other telepsych companies. But yeah, you do need licensing in every state you're gonna do work for. I recently got asked by the company I work for whether or not I wanted a credential in Nevada. Yeah, I'm not ready to do that. I mean, it's a whole other process you got to go through. So that's pretty much how it works.
Okay. And what other big changes do you see in medicine in the next few decades, especially in psychiatry? It seems a little bit more resistant to things like AI taking over.
So I actually sort of goes back to an earlier question. I sort of don't enjoy telepsych. Even now that I'm getting used to it, I don't enjoy it because I think there is something that is missing in the face-to-face interaction. As a psychiatrist, it almost seems antithetical that you're not going to actually see a patient face-to-face. But the reason I decided to do it, in addition to some financial compensation, I sort of had the sense this is where things are going. And I didn't want to be behind. I didn't want to be playing catch-up when everyone else is sort of on the bandwagon. So I wanted to make sure I had my bases covered. I wanted to make sure I at least knew how to do it, what the process was like. So I'm trying to adapt with the times, because I do foresee that telepsych is going to be much more important. As far as where it's going to go or how far it can go, I don't know the answer to that. But it's important for me to try to keep up with where things were going.
Would you choose the same career path again, or is there anything that you'd change about how you did things?
Yeah, I mean, I think if I had all the knowledge that I have now going into medical school, I probably still would have done the same things. I'm pretty happy. I mean, I'm pretty happy with the way things are. I don't really want for much. I have a great life. You know, the kinds of roadblocks and tragedies that befall me are on par with what everyone else's experiences in their life. So I don't think I'd change anything. I don't think I would not change anything because I think it is the end-all and be-all. I'm happy, so I don't think that I would change anything. I guess I'm afraid of what could stink about doing something else, right? I know what psych is all about by this point. I don't know what other fields of medicine would be like, so maybe some of that answer is because of fear, like, you know, what would it actually be like to be doing something else? But I think I'd probably do the same. If the decision was, would I go into medicine again? Yeah, probably. There are other things that I really wish I could have done earlier in life. I wish I could have studied music a little bit more than I had. I think I gave up on music a little too early.
So if you couldn't be a doctor, what would you have been? Would you have been a musician or something else?
Probably not a musician. You got to be really talented to be a musician. I think I'm okay. I know I'm not to the level where I can have a career performing, but I think it'd be cool to have a music history degree, maybe teach music history. I like to write, and so, you know, I have this idea in my head that maybe I could have been a great biographer, one of the great composers or something like that. But, you know, that's probably the only thing that I would have spent a little more time on. But I'm actually okay with where I am.
And last question, what advice would you give us to become good doctors?
The best advice I can give you is to really think about who you are. And what do I mean by that? What I mean is some people go into medicine because they believe that there is a noble purpose to it. They believe that they have certain entitlements that can only come through a high-power profession like medicine. I would be careful. I would really examine who you are and think about what makes you happy before you start making career choices. I've known a lot of people that end up in places where they wish they'd never gone because they didn't think carefully about who they were. Yeah, excellent clinicians, excellent psychiatrists, unhappy, not because that they're doing anything wrong, but they didn't think about it first. I think there's a lot of pressure on medical students to embrace the field of, any field of medicine with so much reverence that anything that happens in their career ends up being a letdown. You tend to overvalue the profession as something really noble, and maybe it's just a job, and that's okay. So just know who you are before you start making decisions about what you want to do.
Okay, well, thank you, Dr. Katinga, for being part of this interview. And thank you guys for watching. If you have any questions, leave it down below in the comment section, and I'll ask Dr. Katinga and get back to you guys. Thank you guys for watching, and have a good rest of your day.
Thank you.